Good afternoon to everyone, respected dean, faculty members. It is my honor and privilege to introduce the international guest speaker, Dr. Munro Rogers. He studied in the School of Glen School in Glasgow, and then he got a medical degree from the Medical School of Glasgow. And he has completed and become a fellow in the Royal College of Surgeons of England, and member of Royal College of Physicians, fellow of the Royal College of Physicians of Glasgow 1986, and he is also a member of the PG Medical Education 2006 from onwards. He worked and retired as consultant surgeon in the general surgery from Bingham Infirmary, South Shields and South Tennessee Health Care Unit from 1978 to 2003. He retired from NHS in October 2003 and worked for some time in AIMST University from 2007 to 2009 as a visiting professor and also as a senior associate professor. And he's a guest examiner and also assessor for surgical examiners 2006. He has given guest lectures and fellowship in different countries, starting like Nigeria, Nepal, Sri Lanka, Delhi, and also in Malaysia for 2 times, Scotland, and Italy, and also for Australia. He's published around 52 articles in 34 journals. Most of them are very famous journals like Archives of Disease of Child, British Journal of Surgery, Lancet, Darlington Postgraduate Medical School, Journal of Royal College of Surgeons of Edinburgh, Gastroenterology Today, Medical Journal of Malaysia, Journal of Pediatric Surgery, Journal of Neonatal Surgery, and many more. Because of time constraint, I am not mentioning all the 34 journals. And he's published 2 books, The Consequences, Causes of Pyloric Stenosis of Infancy in the year 2016, and Pyloric Stenosis of Infancy, The Great Mystery and Revels. These are 2 books being published by him. And is member of the Vascular Society of Great Britain and Ireland, Association of Surgeons of Great Britain and Ireland, Northern Vascular Surgical Group. He was president of South Shields Rotary Club from 2000 to 2001, and was a member of the Newcastle Medical Legal Society. On this occasion, I thank the Dean, Dr. Badrinath Susi Late, for giving an opportunity to be moderator for this lecture by the distinguished internal speaker, Dr. Rogers. I request Dr. Munro Rogers to share his views and experiences in the management of congenital hypertrophic pyloric stenosis. Sir, the floor is yours, sir.
Thank you very much, Professor Kumar. It's a great honor to be allowed to speak on my favorite subject. And as you said, I enjoyed so much being with AIMST and having the opportunity of full-time teaching. This is my wife and I in our home in Scotland, just showing you what retirement can be like. And it does give your mind a sort of liberty that it didn't previously have. Next slide, please. Yes, that's fine. Well, this is a condition which most of you will be aware of. It's quite an easy diagnosis. It's only milk that's vomited. It is not present at birth. It starts about 4 weeks of age, classically. And the sphincter is, the pyloric sphincter is thickened and constricts the outlet of the stomach. It's generally accepted that the thickening is due to overuse of the sphincter. It hypertrophies from overwork. And the operation, which is almost without mortality and nearly always completely curative, is the operation of dividing the sphincter. Next slide, please. Now, in any diagnosis with patients, you listen to the story, you examine them, and you come to a diagnosis. Babies don't talk, but they give you lots of signs, and there are many signs with pyloric stenosis pointing to a cause. Male babies predominate. vomiting at 4 weeks, and it's a continuum. Some babies are severe, some are mild cases, some naturally self-cure. And there is a family history, and if a baby is vomiting around that age and is alkalotic, invariably it means pyloric stenosis. Firstborn babies occur more frequently or get pyloric stenosis more frequently. But the really important thing is that with just temporary medical treatment, and sometimes with no treatment, the babies can self-cure and the condition doesn't return. Now that is very unusual. Next slide, please. The baby on my left shows the typical gastric peristalsis, gastric distension, and sometimes you can feel the enlarged pyloric sphincter tumor. The baby on the right, sadly, has had pyloric stenosis for a long time and is dehydrated and malnourished. Next slide, please. Now, in the early days, the surgeons and the physicians competed with one another to see if they could help those unfortunate babies. The first surgery was gastroenterostomy, which wasn't good. It was very, very difficult to do, lots of complications. The next operation was just dilating the pylorus by through a gastrostomy. And even the adult form of pyloroplasty, dividing all layers and sewing up, that was also used. Medical treatment took the form of atropine. Reduced feeding was found to help, and feeding the baby by enema and thus being able to reduce oral feeding was also found to help. Alkaline powders sometimes orally were used, but the mortality in those days was extremely high. Next slide, please. This is the operation of pyloromyotomy, which is so successful, introduced in 1908 by Ramstead. Next slide, please. Now, some things never change. And what doesn't change is the approach by pediatricians and by medical people to the cause of pyloric stenosis. It's always stated that there is no known cause. Everyone who writes about this, at least in my experience, is writing about little extra things they add to the mysterious clinical conditions, seasonal incidents, this and that, but they don't really, very seldom try and address the cause. Next slide, please. These are some of the very earliest thoughts on cause. The great anteater in South Africa has got a muscular pylorus, which acts as a gizzard. They don't chew. And the mechanical effect of chewing occurs because the pylorus is closed most of the time, and the stomach in its peristalsis manages to have a chewing effect in that it reduces the food material into a fluid state. Another possible extraordinary attempt at cause was to say that it was a reflex spasm of the sphincter in response to phimosis. Another celebrated person thought it was too much calcium in the stomach walls because the hypertrophy is very cartilaginous in its consistency. But frowned in 1903, he thought that hydrochloric acid was present in excess. And he thought, and he was right, that this caused the pylorus to contract. And thus you got hypertrophy, but it was never followed up. Next slide, please. Modern thinking started on various different lines. First of all, a genetic cause. But it's not entirely genetic, because identical twins only in between 1/4 and 1/2 of cases, the second twin also has pyloric stenosis. And they've made many chromosomal studies and nothing has come up. Nitric oxide relaxes involuntary muscle, and it was considered that there might be a deficiency, but there's no evidence of this. You don't have sphincter controls. The only controls that have been used are pyloresis from babies who've died many hours before, and so there's no controls. They've tried to measure genetically the nitric oxide synthetase gene to see if there's a difference, and there's no difference. Similarly, abnormal accumulation of growth factors in the sphincter doesn't have any controls. And work hypertrophy occurs because when a sphincter repeatedly contracts, it becomes big because it's attracting growth factors to the sphincter. So this makes no sense. There's no evidence of H. pylori, although that might have been quite a good possible cause because it does produce hyperacidity, but there's no difference. The inheritance is multifactorial, just like the inheritance of height or any multifactorial inheritances like that. Next slide, please. Our pathway to inherited primary hyperacidity as the cause started with the accidental discovery of Dr. Robert Miller's work in normal development. We then went on to study gastrin to see if it caused, as I'll tell you later, a wave of gastric hyperacidity. And we discovered again by accident that newborn babies had high gastrins, and the gastrins became even higher 4 days later. We thought that gastrin itself might have a cause to play, either directly or through its effect in producing acid and spasm of the pyloric sphincter, but we found that the gastrins were normal. And then we found that pyloric stenosis babies have significant hyperacidity, and that should be which remains after pyloromyotomy. So it's not due to retained acid. And you can make puppies have pyloric stenosis by making them hyperacid, by giving pentagastrin to their mothers before birth. Next slide, please. So this was the paper that I accidentally discovered in the 1970s. It shows that soon after birth, once you've emptied the baby's stomach, you get a wave of hyperacidity which lasts for 2 or 3 days and then disappears. And then round about 10 days later, it seems to recover a bit, having fallen to a low level. And this was described by an anaesthetist who thought in 1941 that a chemical might be transferred from the mother to baby during labor to cause this. He didn't know about gastrin, and he was just looking into the future. Next slide, please. So we thought we might be able to add something to this. So we measured this possibility that maternal gastrin was being transferred from the mother to the baby. So we measured gastrin in the peripheral venous blood of the mothers at the time of birth. And then we measured cord gastrin at the same time at the moment of birth. And the cord gastrins, the baby gastrins, were much higher than the mummy gastrin. So we thought this rather stopped the idea that gastrin was being transferred from mother to baby. Next slide, please. In fact, subsequent studies have shown that maternal transfer of gastrin during labor does occur. if gastrin's infused into dogs, the canine fetus demonstrates hyperacidity because of the gastrin. The maternal venous gastrin in humans rises during pregnancy, peaks at labor, and within 30 minutes of labor has fallen. And more significantly, the placental gastrin is very high. So we had failed to recognize that the gastrin going into the fetus was coming from the placenta rather than from the maternal venous supply. Puppy dogs develop pyloric stenosis when pentagastrin is given to their mothers. This was a famous experiment by Professor Dodge. And the other observation is that whenever labor occurs, then the newborn gastric pH is lower. The process of labor produces acid in the newborn's stomach. If the baby is born by cesarean or without a period of labor, the acidity in the stomach is not so great. Next slide, please. Anyway, the same tests that we had done in 1974 showed that, and quite surprisingly, that the level of gastrin in neonates rose quite significantly from day 1 to day 4. And the individual correlation between day 1 and day 4 only occurred with babies born as a result of being induced by syntocin. If you look on the left, on the day 1 level, you can see that the cord levels are much higher in the spontaneously born baby. And one interpretation of this is that in the spontaneously born babies, gastrin's being transferred from mother to baby, and disallowing an individual correlation. Next slide, please. So we still don't know if that actually is the case. But one thing that we speculated on in this paper in 1974 was because gastrin was rising from day 1 to day 4. We knew this, and because we knew that acidity would be present, and we knew that it was present on day 4 and was very small on day 1, that is not only day 1, but at the time of birth, before the amniotic fluid, which is in the baby's stomach, was aspirated, then we thought that gastrin would be rising at a time of acidity, which is what should not happen. It should be in a negative feedback. And we wondered about the negative feedback not being operative at birth. Was this a temporary Zollinger-Ellison syndrome? Next slide, please. What we imagined would happen with normal babies was on the left-hand side. The gastrin, which is blue, would be rising. The acid would be rising. And then when negative feedback was established, both would then fall together to get into the normal range. In babies who develop pyloric stenosis, the gastrin would rise and the acid would rise, but because these babies had a greater parietal cell mass or had a much greater potential to produce acid, then their peak acidity would cause such repeated pyloric sphincter contractions, there would be gastric outlet obstruction, which would also produce high acids, and the acids would continue to be high, continue to cause pyloric sphincter contraction and produce pyloric stenosis. That was what we imagined would happen. Next slide, please. Indeed, other people after this have often, without analyzing why these things happen, have reported those things happening. If gastrin is being maximally stimulated without restraint, when you have a meal, when the baby feeds, gastrin can't go up any higher. And it's only when the gastrin has fallen because it's under negative feedback control that then when you give a feed, you get a postprandial gastrin increase. This was first reported by a namesake of mine, Rogers, in 1978. And then in 1980, on this graph on the right-hand side, you can see that at 2.5 days and at 6 days, the gastrins are high. And when these babies have a meal, there is no postprandial increase. Whereas at 13 days and 24 days, you can see that the gastrin, that the feed makes an increase in the gastrin both at 13 days and 24 days. And the presumption is that at those days, feedback has been established. Next slide, please. I came across in a paper in 1969 by Adjunct, for me, a very important paper, which was just showing the time-related acidity in normal babies, in normal developments. And you can see there's a temporary peak of acid secretion between 14 and 17 days. And then it falls to about 25, 32 days. The vertical rise thereafter is false and misleading because the time scale is quite different at that time. It's much concertinaed. All the parameters of gastric acidity are increased: intrinsic factor, proteins, everything. So this was supportive evidence looked at retrospectively. Next slide, please. Curious enough, again, an observational study without any explanation on puppies. Puppies develop pyloric stenosis too, incidentally, showed that the gastrin was higher at birth than in adults. It rises and peaks in day 7. The peak is a temporary peak. And when you give pentagastrin to increase acid, there's no effect until after the 9th day, when acidity is falling anyway due to the establishment of the negative feedback. And during the time when acidity is increasing, antral contractions and presumably sphincter contractions are increasing. Next slide, please. The effects of this artificially elevated gastrin and acid during the first few weeks of life are very important. The neonatal gut is developed by high gastrins. Gastrin has a trophic effect on the development of the gut. Enteric infections are prevented by artificially elevated high acids, both from the maternal gastrin at labor and by maximally secreting gastric mucosa from an unrestrained gastrin. And when feedback matures, the developed gastric mucosa is now well developed to allow an independent digestive life. So the feedback the negative feedback immaturity is very important. Next slide, please. So anyway, we were still at the stage of wondering what actually caused pyloric stenosis. Was it too much gastrin or too much acid? Next slide, please. This was one of our first attempts at trying to make a causation which explained all the clinical features. We knew that gastrin was increasing in the first week of life. We thought that, or its effect on acid, would produce pyloric spasm. you would then have a pylorus which was stopping the stomach emptying. The baby would continue to be fed. The antrum would distend. There'd be more gastrin released because that's what causes gastrin release, distension of the antrum. And you'd get more and more spasm, more pyloric hypertrophy. So we set out to measure gastrin in pyloric stenosis babies. Next slide, please. And it was normal. So then we wondered, was it simply just inherited primary hyperacidity? And as I hope to be able to convince you later, it did explain all the clinical features. Next slide, please. The things that cause sphincter contraction are principally acid. On the slide, on the little diagram on the left, the middle bar, the highest bar, is the effect that acid has on sphincter contraction. When gastrin is added to it, it reduces the effect, curiously. And the graph on the right, this is an important graph. The top line is antral contractions, the middle line is contractions of the pylorus, and the bottom line is contractions of the duodenum. And when you get a meal, when the baby is, this is not a baby, this is, I think, in biological terms, an experiment, but it can be shown that it's the meal that produces the most rapid and greatest amplitude of pyloric sphincter contractions. So both things contract the sphincter, acid and feeding. Next slide, please. And the other factor, which is also very important, is that outlet obstruction for whatever cause causes acid hypersecretion and hypertrophy of the gastric mucosa. Experiments in rats by artificially narrowing the pylorus produce gastric hyperacidity and sphincter hypertrophy. The hormone ghrelin, which is released from the stomach, also when there's outlet obstruction and increases appetite, is also released in rats at any rate by pyloric obstruction. Next slide, please. Now, the normal conventional explanation of pyloric sphincter contraction really began with this gentleman, Walter Bradford Cannon, who introduced the fight or flight phenomenon, the adrenaline business. He introduced, or rather he continued to support homeostasis and the importance of that. But he also had an influence in working out why the sphincter contracts. He described the Cannon cycle. Acid entering the duodenum causes sphincter contraction. Acid entering the duodenum causes secretin to be released, which alkalinizes the duodenum, and the sphincter then opens again, and then acid re-enters and the sphincter contracts again. This was the Cannon cycle. Next slide, please. Now, how does acid constrict the sphincter? Well, there are acid sensing systems in the duodenum which stimulate an immediate neural reflex. This is a relatively new area of study, and Dr. Holzer has been much involved in this. As acid increases in the stomach, so it releases prostaglandins, and prostaglandins cause sphincter contraction. For example, PGE1 infusions used to open up the ductus arteriosus in cyanotic congenital heart disease are associated with pyloric stenosis. So prostaglandins are released as acidity increases, and they reduce acid secretion. So that's another feedback mechanism, but at the same time, they have the ability to contract the sphincter. Next slide, please. We measured acid secretion in pyloric stenosis after carefully emptying the stomach. And we found that babies with pyloric stenosis were the only babies that had free acidity. They were much more acid than normal babies. Next slide, please. Others, particularly Professor Sato from Japan, has measured not only basal acid, that was basal acid that we measured, but maximal acid output after pentagastrin, and found that basal acid and maximal acid was much greater in pyloric stenosis babies. Next slide, please. The consensus is that with pyloric stenosis, gastrins are normal. They actually ought to be a wee bit lower than normal, but they're because of the negative feedback, but they're normal. Others, not others, but just one study from Professor Sato has shown that both gastrin 17 and gastrin 34 are elevated both in fasting and post-feed state in pyloric stenosis, but this is just one study, and most studies show a normal fasting gastrin. Next slide, please. So we thought it was acid, and it was an inherited parietal cell mass at the upper range of normal. It wasn't pathological, it was just at the upper range of the normal distribution curve. Because babies with PS get late onset hyperacidity problems, gastrectomy for duodenal ulcer. You get sphincter hypertrophy from repeated contraction during the trophic effect of neonatal high gastrin. It's a very powerful thing to have gastrin when you're getting work hypertrophy, high gastrin, when you're getting work hypertrophy from repeated sphincter contractions. And babies who are vomiting and who are alkalotic almost invariably have pyloric stenosis because they're losing much more acid. And acid-related hunger and relative overfeeding is another way in which pyloric stenosis can become progressive and potentially fatal. Next slide, please. This was one of our more later slides where we started off considering that this was an inherited parietal cell mass producing acid. You get pyloric holdup. The baby's still, despite this, despite even vomiting, as feeding continues, and you maybe get a gastrin increase from pyloric, from antral distension, more acid, producing repeated contraction and pyloric stenosis. And the aging process, by introducing a negative feedback process and by getting the pylorus to open up with age as it gets bigger, produced a cure, as did medical antacid treatment. Atropine, incidentally, reduces gastric acid secretion. Next slide, please. Those of you who are still listening to this talk might have wondered whether or not the hyperacidity that we measured was just due to acid not leaving the stomach, but it's not due to that. Even 1 week after successful pyloromyotomy, acidity remains high, and the baby and the puppy dogs who develop pyloric stenosis from pentagastrin to their mothers are starting from scratch to get pyloric stenosis. Acid does it all on its own. It's not retained acid. Next slide, please. Boys are rather premature boys have more acid than premature girls. The reason that we know that is because a nasogastric tube is necessary in the premature babies, and you can measure acid secretion, and it's presumed that the same difference applies in mature babies. Next slide, please. Now, a firstborn baby has a first-time mother who we presume is more anxious to refeed the hungry, bouncing baby boy that she has. Because these babies are typically hungry and good feeders. It's also been shown that more frequently fed babies, this was a huge study, over 1,000 pyloric stenosis babies, more frequently fed babies present with pyloric stenosis at an earlier time. So if they're going to get pyloric stenosis and they're being more frequently fed, they present earlier than 4 weeks. Next slide, please. This is just demonstrating this, that if you're fed 3 hourly, you present at 21 days, 4 hourly, 27 days. And if you're measuring the size of the pyloric tumor, it's directly related to the age at operation. It's a progressive thing, it takes time to develop. Next slide, please. This firstborn effect is only seen after week 3. You require 2 weeks of being fed inappropriately frequently in order to get it. The graph shows that it's only this difference between firstborn and otherborn, and second, thirdborn, and so on, is only apparent from the third week after. Up to 3 weeks, there's no difference. Next slide, please. This is Professor Dodge's work, who's been a great supporter of my interest in this. And he gave pentagastrin injections to 20 bitches. More than a quarter of 84 babies developed vomiting, and at post-mortem had pyloric stenosis. Even more babies when pentagastrin, which produces acid, of course, was also given to the babies. And some of these babies had duodenal ulcers. Indeed, simply stated, pyloric stenosis of babies should be considered similar to the duodenal ulcer of adults. It's just that the swelling and the hypertrophy of the pyloric sphincter, which you see in adults too, is absolutely critical with pyloric stenosis babies because it doesn't allow the feed to get through. They share the same abnormality with blood groups and the same hyperacidity. Next slide, please. So this is the pathogenesis that we've arrived at. The key to all this is a large parietal cell mass. The parietal cell mass, particularly at the time when there's the normal peak acidity and normal development, becomes critical hyperacidity. The acidity with the normal developmental temporary peak acidity becomes so critical, so acid, that you get repeated pyloric sphincter contraction. You get the acidity also increases appetite, and you get overfeeding. And they combine to form sphincter hypertrophy, and pyloric stenosis is the natural consequence. Surgery is curative forever, and atropine is curative sometimes, but less often, forever, because it's addressing a temporary problem which they grow out of. And if they don't if it's a progressive condition, fatality occurs. Next slide, please. This is the book which professor, which the Dean kindly showed, which Elsevier has published, which is pretty comprehensive. And it tells you all sorts of other things, including more about the history and more about many of the things I've talked about. Next slide, please. It's been a great honor for me to be able to talk to you all about this condition. It's a pet subject for me. It's had some support from the pediatric establishment, but not much. I think they don't like a general surgeon invading their territory. But it has been a great honor, and thank you so much for inviting me to talk to you.